Good evening. Tonight's top story. The front line of defense against systemic disease isn't always where you'd expect. New data reminds us that the dentist's chair is often the first place life-altering conditions are identified, specifically AIDS. But before we dive into the clinical manifestations on how dentists manage this disease, let's take a look at this essential health update on the nature of the virus itself.
HIV is a virus that causes AIDS. One common way it is spread is through unprotected sexual intercourse. The virus can be present in certain bodies such as blood, semen, vaginal fluids, and breast milk. During unprotected intercourse, infected body fluids from one partner can enter the other partner's body. The virus can pass through small tears mucous membrane and enter the bloodstream. Once inside the body, HIV targets and infects important immune cell called the CD4 cells. The virus multiplies and gradually weakens the immune system. HIV transmission can be prevented with protection, regular testing, and proper medical treatment. AIDS is a serious disease that weakens the immune system. Here are the 5 warning signs you should know. Sign number 1, rapid and unexplained weight loss. Sign number 2, frequent fever and night sweat. Sign number 3, constant weakness and extreme fatigue. Sign number 4, swollen lymph nodes in the neck, armpit, or groin. Sign number 5, frequent infections because the immune system becomes weak.
We're here at the clinical site to show you what the sentinel signs look like. If you're a practitioner or a patient, these are the red flags you're tracking. First off, we list down the factors that predispose the patient to oral lesions. These are a CD4 plus count of less than 200 cells per cubic millimeter, a viral load of more than 3,000 copies per cubic millimeter, xerostomia, poor oral hygiene, and smoking. Let's take a look at some of the presentations HIV can cause in a patient's mouth. For fungal infections, we have candidiasis or yeast infection, which is caused by C. albicans and may be the first apparent sign of HIV infection. It occurs in most patients infected with HIV. HIV infection should be considered in patients with repeated oral candidiasis in the absence of other associated risk factors such as steroid or antibiotic use. There are several clinical types of candidiasis, and diagnosis is based on clinical presentation and exfoliated cytological exam. These types include pseudomembranous candidiasis, erythematous candidiasis, and angular cheilitis. Pseudomembranous candidiasis is the most common type of candidiasis in HIV-infected individuals. It is characterized by removable white or whitish yellow, small solid rounded patches, often on the mucous membrane of the cavity of the mouth, roof of the mouth, and vestibule. This type tends to be asymptomatic and alterations in taste are common. Another type is erythematous candidiasis, which appears as red flat lesions commonly on the dorsal surface of the tongue, mucosa, and posterior hard palate. Some patients may complain of oral burning, most frequent when eating spicy or salty food, or when drinking acidic beverages. Another form of fungal infection is angular cheilitis, which presents as painful erythema and fissures with slight crust formation in the corners of the mouth. This may occur with or without erythematous or pseudomembranous candidiasis. One of the strongly associated viral indicators is oral hairy leukoplakia caused by Epstein-Barr virus. It appears as white corrugated lesions, sometimes hairy in appearance, primarily on the lateral borders of the tongue that cannot be wiped away. The most common neoplastic lesion associated with AIDS is Kaposi sarcoma, in which HHV8 is implicated as the etiological agent. The palate is the most commonly affected site, followed by the gingiva, tongue, and oropharynx. The lesions are often multifocal and usually present as flat purple or red-brown plaques or as raised nodules.
So what's the protocol when a dentist identifies these signs? It's about management and movement. First, we manage. Dentists use standard precautions, treating every patient with elite infection control, If we suspect a systemic issue, we check the vital labs, CD4 counts, and viral loads. We focus on reducing pain and controlling local infections like thrush. But the most critical step, the referral. A dentist isn't just a tooth doctor, they are a bridge. We coordinate immediately with infectious disease specialists to get the patient on highly active antiretroviral therapy and with oral pathologists for biopsies if we see suspicious growths.
The dentist acts as a coordinator in a medical home model. The dentists need to have immediate referral to infectious disease specialists if oral signs suggest that the patient is not on or is failing highly active antiretroviral therapy. The dentists have to refer the patient also to oral pathologists for biopsy of any atypical soft tissue lesion. For example, suspected Kaposi sarcoma. And lastly, the dentists have to refer the patient to nutritionists also if oral pain is preventing the patient from maintaining adequate caloric intake, or in other terms, wasting syndrome.
The message for the public is clear. Your mouth is a mirror. We tell our patients that keeping a 3-month recall appointment isn't just about cavities. It's about monitoring their immune health. Using high fluoride products and maintaining a strict home routine can prevent the devastating oral bone loss associated with AIDS.
That's all for our medical special. Remember, health starts with a smile, but it ends with awareness. For more information on the oral systemic link, check the links in our description. On behalf of my team, I'm Jade, and you're watching the Oral Health Desk. Good night.